Hello, my name is Donnie Luper. I'm a practicing endodontist from New Bern, North Carolina. I've been practicing dentistry for over 30 years and doing strictly endodontics for over 20 years. I got my love for endodontics when I was in the U.S. Navy at an outlying clinic in the Philippines. I've lectured internationally and in the United States for over 20 years. I have decided that endodontics is the field that I love. But the most important part of endodontics is irrigation. I've come to realize that over my 20 years of practice, and that is where my passion lies. So today we are going to be talking about irrigation of the root canal system and teaching you how to do it properly. So let's get started, and let's talk about irrigation forces in nature, and especially about hydrodynamics. This picture is a great representation of the Colorado River and how movement of fluids has carved a complete canyon by the Colorado River. The thing about hydrodynamics is that the solution, as it moves, carries silt. It moves things down the river. It's a mile deep in some places because of the power of moving water. And it's taken 17 million years of this fluid-driven erosion to carve this magnificent canyon. And in endodontics, we have the same ability to use the forces of hydrodynamics, especially using an endoactivator. This cleared tooth shows the fact of how the solution moves. The air bubbles are in there and they create movement of the fluid, which cleans out the canal in lateral canals, accessory canals, and fins and isthmuses, which we could not do unless we had some type of hydrodynamic fluid movement. So the question is, can I do it or not? We need complete access to the root canal system. One of the things I like to think about is that we're creating a funnel when we do our preparations so that we can get irrigant into the entire root canal system. My journey with irrigation started with this picture that a friend showed when I was at a meeting in Kenya. He was talking about how to properly clean and shape this canal, and I immediately went to the fact that if I can clean and shape this canal, how in the world am I going to get all the debris out of those fins and isthmuses? So this started my journey with irrigation and me trying to figure out how I can get solution into those places. My deciding factor in everything that I do is what would I do if I was doing endodontic therapy on myself. At courses I've taught, I've had people ask me, well, what if you were doing it on your mother-in-law that you don't get along with? And I personally myself would do it the same way I would do it on myself, because if I didn't, I would have to deal with that mother-in-law and things would not be great. So I try to do everything I do thinking about how I would do that procedure on myself. Let's look at some anatomy in these pictures. Sodium hypochlorite, it's been shown in many different studies, will not clean isthmuses by themselves. You need some type of agitation of the solution in order to get into these little isthmuses and get them clean. For instance, the picture on the right. It's like a washing machine. A friend of mine, Mike Nimick, who also lectures, made this analogy that you don't just put clothes into a washer and let them sit there and soak. You have agitation and you have rinse cycles of the machine. And in those situations, you're using that agitation to remove the debris out of the clothes. Well, it's the same principle in irrigation. We can't use just an irrigating solution. We have to agitate that solution in order to get into these fins, these isthmuses, and these lateral canals. This slide shows what happens when a file is in a canal. The file will touch the wall in some places. In other places, it will not touch the wall. The top picture shows the fact that there is still predentin and pulpal debris on the wall of the canal where the file never touched it. But areas that the file touches creates what's called smear layer. When I was in dental school, we never even thought about smear layer and what we need to do with it. And these instrumented surfaces have smear layer. The untouched areas are covered by tissue remnants, collagen fibers, cellular debris, inflammatory products, bacteria, and their byproducts, endotoxins, and the like. There have been studies that have shown that in complex root canal systems that the files do not touch up to 40% of the walls, and thus they are uninstrumented. So what's going to get those canals clean? The only thing is irrigation. This picture shows the areas of green, which are areas where the file has touched. The red is areas where the file never got to, and the only thing that's going to get to those areas is irrigation. So the only thing that can clean all parts of the root canal is irrigation. But we must know how to do it properly. I have three key thoughts when I think about irrigation. Number one, instrument shape and irrigants clean. My main thought is that the solution to pollution is dilution. The more fluid that I get moving in the canal and thinking about hydrodynamics, the more of that pollution that's going to come out of the canal space. So my big question is irrigation the most important step in endodontics? The longer I've practiced, I think the answer to that is yes. So why do we use rubber dams? I don't think that it's an optional step in endodontics. I find that it's mandatory. It does several things for us. It helps us do faster root canal therapy. It's safer. It keeps solution from getting into the patient's mouth, and it keeps you from dropping a file down into the canal space. When you're talking about that, you have to think about the legal aspects of what would happen if you dropped a file into someone's mouth. If you drop a file into a patient's mouth, they will go to the local specialist in the area and ask them what they do. That determines the standard of care. It also allows for safe and effective irrigation, and this is critical. I don't consider using rubber dam something that's even an option. Irrigation and activation also is done and will generate aerosols and spray. You must have a rubber dam on to protect the patient's tissues and to keep that debris and that solution from getting into their mouth. So what is there to clean when we do endodontic therapy? This slide on the left shows a tooth that has a radiolucency. We used to think that these radiolucencies were sterile and did not have bacteria in them. But that was because we were doing aerobic culturing. We didn't have sophisticated anaerobic culturing to be able to isolate anaerobic bacteria. So what is there actually to clean inside the root canal space? Number one, there's bacteria and biofilm. We didn't even think about biofilm when I initially went through dental school. And then the ADA came out with this mandate that there's biofilm in the water lines, so we started looking at the fact that there's biofilm in the root canal system. There's also pulp tissue, there's predentin, dentinal debris, exudate, and smear layer when we use instruments. In this retreatment case, we see a radiolucency, but yet the patient is asymptomatic. But does that mean that there are not microbes present? The answer to that is no. This is a culture of the tooth in those last couple of millimeters of this distofacial root. And you'll see that there's all kinds of bacteria that are in that canal space. So in this retreatment case, we should have a high level of success if we go in and are able to remove the microbes out of this canal system. So what is in smear layer? And we need to look at necrotic teeth and vital teeth. In the smear layer of a tooth that had necrotic tissue in it, after instrumentation, we will find organic dentin, we will find inorganic dentin, pulp tissue remnants, microbes, and antigens. The difference is a vital tooth does not have bacteria in it, unless we get leakage from underneath the rubber dam. And so, if we look at what's in a vital tooth, The only thing that's in that smear layer is organic dentin, inorganic dentin, and pulp tissue. We don't have microbes or antigens, so we don't have to remove those. Does that mean we don't use an antibacterial medicine in this? The answer to that is no. We always try to use antibacterial medicine when we're irrigating the canal systems. So, is our purpose just to rinse or to kill bacteria? If we wanted to just rinse out the debris in the canal, we could use water. But we know we have to use other solutions to kill bacteria, to dissolve pulpal debris, and to do other things in the root canal system. We will look at those when we talk about irrigating solutions. Let's talk about biofilm. Biofilm is always found in teeth with apical lesions. The biofilm has this top layer and this bottom layer, and there's bacteria all through the biofilm. So what is biofilm? As I mentioned previously, I never really even thought about this when I was in endo school. But through reading the literature, it's very evident that it is in all teeth with necrotic tissue in them. Biofilm is this aggregate of slowly growing bacteria that is embedded in this polysaccharide slime matrix, which is produced by the bacteria. This provides protection for the bacteria. The low metabolic rate of those microorganisms and the protection by this polysaccharide material leads to increased resistance of removal by disinfecting agents and the ability to kill the bacteria that's in that polysaccharide matrix. So this picture shows you how this polysaccharide matrix provides protection for the bacteria that are embedded in this slime. A protective almost covering, if you will, of these bacteria from disinfecting agents which could get into them and kill them. So the question is it possible to get into this area and kill these bacteria? We will show when we discuss several of our irrigating solutions that yes, this is now possible. And if we don't, and we leave killed bacteria in the canal space, in biofilm, it can still have antigenic potential, which can cause failure of the root canal that you're performing. So now we have described the first part of the reasons that we want to remove all of the debris, and now we're going to move on to actual techniques, devices, and tools and solutions. So, is there a recipe for success? And I want to tell you that I think the answer to that is a definitive yes. We have current irrigation techniques that we can use. We now can agitate our solutions, which give us greater flow in the canal using those hydrodynamic principles we talked about. We have needles, which can deliver within a couple of millimeters from the apex. We have irrigating solutions, which kill bacteria and help remove biofilm. And our final rinse prepares us for our obturation. So, there are two types of irrigation, passive irrigation and active irrigation, and we're going to talk about each of these. Passive irrigation is the process of the solution just sitting in the canal and using the physical properties of that solution to help us achieve some of our irrigation principles. The picture on the left shows sodium hypochlorite just sitting in the canal, and you can see that it bubbles up debris, but without movement, it can't get down into the canal spaces and use the hydrodynamic principles we already talked about. So what are the benefits of passive irrigation? It's okay for friction reduction when we're using different files. It's okay for temperature control, but the effectiveness of it is very questionable. It's not much studied because it just doesn't have a whole lot of effectiveness. On the other hand, active irrigation keeps the irrigant in motion in the canals. This is a key factor for effectiveness, for both tissue dissolution and antimicrobial effectiveness. Here's a slide which shows the effect of agitation on tissue dissolution by sodium hypochlorite. This study used 0.02% sodium hypochlorite and 0.06 sodium hypochlorite with and without agitation. This study found that with agitation, the canals are 12 times cleaner. That is very significant. And if you were going to do a root canal in my tooth, you would be using some form of agitation. So what are the various techniques that we have for active irrigation and moving our solution in the canal system? We can agitate by the syringe and the needle, the simple pumping in and out motion of the syringe which moves solution up and down the canal. I read in the literature that someone has said that you can agitate the solution by pumping a gutta-percha point up and down in the canal. I don't see how that would be very effective and really don't recommend that. Then there's the Endoactivator, which is a device developed by Cliff Ruddle, and ultrasound, which has also been used. The studies will show that smaller sizes of your irrigating syringes gives you better control with less force. You don't want to use a big syringe up at the top. Although it may contain more irrigating solution, you want to use one of the smaller syringes on the bottom. Yes, you may have to refill it more often, but use something with better control that delivers less force. Let's describe needle irrigation for just a moment. It's very important that you use thin 27 or 30 gauge needles. I like to use the ProRinse needle, which is a 30 gauge needle. If you do not use a side vented needle, I can guarantee you, you will have a sodium hypochlorite accident sometime in your career. The fact that it's side vented makes sure that that solution does not come squirting out the end with tremendous force. I have my assistant measure my needles 2 to 3 millimeters from my working length. When I'm doing that pumping motion, I never allow the needle to bind in the canal. I never want to obstruct the canal and have it bind at all. If you do, it will create greater force, which will force solution out the root end. And never force the solution. Never feel like you've got to push harder. Just a gentle pumping motion with the solution coming out as you're going in and out. And always keep that needle in motion. Never let it sit still. Here's a tip for you. Here's how I have my assistant set my needle 2 to 3 millimeters short of my working length. I use an endo block and have her put a gentle 45-degree bend at the length that I tell her. You don't want it to be a 90-degree bend because it'll kink the needle and block the irrigation solution from coming out. I use in a multi-rooted tooth the shortest canal and have her set it 2 to 3 millimeters short of that length. For instance, if my shortest canal in a lower molar was 20 millimeters, I will tell her to set my needle at 18 millimeters. And then I will know with the other lengths of the other canals that I will just take it to that length. This video that you're going to see will show a clear plastic block with blue dye in the canal space. When we start irrigating with our side vented needle, you will be able to see how the solution flows about a millimeter past the end of the needle. You can see now this take place, and you can see the effective range is only 1 to 2 millimeters past the end. This is why I have my assistant set the needle 2 millimeters short of the working length. This will show you how small metal and niti needles will have difficulty reaching the apical area of the canal. The bottom picture shows you that even with good irrigation techniques, there's still debris in that apical area. So we've got to figure out a way to get rid of that if we're going to have success. Needle irrigation, and you notice I say when carefully done, gives excellent results cleaning the canal. Again, our biggest challenge is the apical part of the canal. I'm very thankful that Cliff Ruddle invented the Endoactivator. It's an ergonomic, cordless, light, battery-operated device which helps us in activation of solutions in the canal. It has a nice contra-angle design so that we can get it into those difficult posterior teeth. It has an on-off button and single-use tips, which are made of plastic, which will not cut dentin. So you can use them in those curved canals so that you're not having to worry about whether you're removing any dentin and transporting the canal. You want to choose your tip size based on the apical size of your preparation. You need to leave room in the apical area for vibration of the tip. This is important because if it binds, you're not going to get the tip moving, and so you're not going to get the hydrodynamic properties that you're looking for. 3 size tips: small, medium, and large. And for infection control reasons, there's a protective barrier that you put over the whole handpiece and then attach the single-use tip on top of that. If you're working in a posterior tooth, for instance, a mesiofacial canal of a lower molar where that canal is sometimes hidden up underneath the cusp tip, you'll want to use a bending instrument to bend the plastic instrument so that you can get it into the canal space. The technique for using an endoactivator is to use the proper size tip. You want to fill the canal and the chamber with irrigant so that there will be solution that will move up and down and give you your hydrodynamic action. Place the tip in the canal and then activate it. If you activate it before putting it into the canal, the fact that it's plastic will make it more difficult to get it into the canal space. And I use it for 30 seconds for each canal with sodium hypochlorite during my final rinse, and 10 seconds for my final rinse with my Q-Mix. The endoactivator is actually a sonic instrument. It has an effective range of 2,000 to 10,000 cycles per minute, depending on the setting that you choose. This setting button is found on the bottom of the endoactivator. I like to use 10,000 cycles per second based on my observation of cleared teeth and plastic blocks. It seems that you get more fluid movement with that, thus giving you a cleaner canal. But I have a friend who sets it on 2,000 cycles per second, and he wonders why I do 10,000. So it's an individual thing for you to be able to choose. There's another way to use activation, and that's by ultrasound. The properties of ultrasound are that it moves the liquid effectively, it uses cavitation and acoustic streaming to provide the hydrodynamics, it has the high flow rate of the liquid, it's widely supported in the literature. The difficulty with this is that sometimes if you use a file, it will remove dentin and cause transportation as opposed to the endoactivator. One of the devices you can use for ultrasonic irrigation is the Pro Ultra Piezo Flow. John Newstein and several others developed this to be put onto your Pro Ultra ultrasonic unit. It has solution which flows through the attachment and has a smooth tip which will not cut dentin. Other people use the ultrasonic K-file sonophile, which also attaches to the ultrasonic unit, but if you use this, it is a file and it will cut dentin. So I would recommend that you never use this in a curved canal. I use the endoactivator in my practice 99% of the time. The only time I use this sonophile is if I have a large open apex case and I'm not worried about touching the walls of the canal. So let's shift gears now and talk about the different irrigating solutions that are available to us as practicing dentists. These are the ones that have been used. Water has little effect. Yes, it will give you some hydrodynamic action, but that's only one part of the puzzle. Remember, we're also looking for things that are antibacterial and do other things to remove debris out of the canal. We'll use sodium hypochlorite. We'll talk about EDTA and citric acid, chlorhexidine, and Q-Mix 2-in-1 solution. Our number one solution that we want to use is sodium hypochlorite. It has several properties which are key in irrigation. It dissolves necrotic pulp tissue. It also will dissolve predentin. and it slowly dissolves vital pulp tissue. It dissolves biofilm. That is imperative in a necrotic tooth. And it kills the bacteria that are in that polysaccharide matrix. And it inactivates endotoxins. These are all properties that we need in an irrigating solution. But its effectiveness depends on the concentration of the available chlorine and the pH of the solution. Some of the concerns that people have expressed about using sodium hypochlorite as an irrigant are that it's caustic to the periapical tissues and may weaken dentin. But if you're using proper techniques with our needle irrigation, you really should not have to worry about it being caustic to the periapical tissues. Other people worry about the fact that it impacts the integrity of the exposed collagen. This high concentration of sodium hypochlorite will dissolve tissue faster than the low concentration. 6%, much more so than 1%. This is some vital tissue which is suspended in solution, and you can see the bubbling effect on the left photograph. Do you realize that right now sodium hypochlorite is now 8.25%? It's super concentrated. It just changed about a year ago. So some of you may want to dilute it, others of you may want to use it full strength. I personally use 3 parts sodium hypochlorite and 1 part water and dilute it to 6% right now. Here are some other irrigating solutions that have been used: EDTA and citric acid. They dissolve inorganic tissue but have no effect on organic tissue. They have no effect on bacteria whatsoever. They impact the effectiveness of sodium hypochlorite by reducing the available chlorine, so you may want to think about using this in combination with sodium hypochlorite. Chlorhexidine is another solution which people have used as a final rinse many times. It has no effect on tissue whatsoever in dissolving it. It does not dissolve biofilm, but it does kill bacteria, but it takes a little bit of time to do that. One of the good properties of chlorhexidine is that it has what's called a substantiative effect, and it remains in dentin, and it's been shown to improve long-term bonding to resins. And then we have a material, surfactants, which people put in our irrigating solutions, which reduce our surface tension. If you go back to freshman chemistry, you'll remember using solution in the micropipettes that we put in there so that it reduces the surface tension and the van der Waals forces, which will then allow the solution to move down into very, very small spaces. It has no antimicrobial effect, but improves penetration into very small areas of the root canal system. It's found in Q-Mix, Chlorextra, and Chlorex Plus. Antibiotics in an irrigating solution really are not routine and don't have a lot of place in endodontics. It's valid for some special situations, for instance systemic infections, but locally doesn't have a whole lot of effect in irrigation. So why not just one irrigant? I'm waiting for that day. I can't wait for the day when one irrigant will do everything. But now we don't have just one irrigant which will do all of our required tasks. So what do? Well, this is where we must have an irrigation protocol, and we must have an area where we do it systematically. This is my house. I love to put up Christmas lights. I put up about 40,000 every year and start in September. This is not done haphazardly. If you look at this, I have done it in the systematic pattern. It may be tacky to you, but it's beautiful to me. But it's done systematically where I have labeled cords, I know which lights go on which tree, and I do it the same every year. That's a systematic progression, and that's what we must have when we do irrigation techniques. So, I have 2 protocols I basically use. One is a shaping protocol while I'm using files in the canal space. I irrigate every time that the file is removed from the canal. I will then use my endo activator with solution in the canal and agitate for 10 seconds in each canal. Then I irrigate again. It's like the rinse cycle on a washing machine, rinsing that debris out, and I recapitulate with a 10 hand file. Then I take my rotary file back into the canal and repeat the same process over after I take the file out and wipe it. And then I have my final irrigating protocol, and there have been many different protocols that have been used throughout time. First of all, the classic protocol was using sodium hypochlorite and just EDTA. We used sodium hypochlorite to kill our bacteria and do all the things that sodium hypochlorite does for us. And then we used EDTA to remove the smear layer so that it was a two-process step. So then we had a classic protocol number 2, where after using EDTA, we have opened up the tubules, and some people felt like it was good to go in with sodium hypochlorite so that we could get that solution into the tubules and kill the bacteria in there. But we found that this may be a problem. Using sodium hypochlorite again after EDTA or the citric acid causes a lot of erosion of the dentin. Now, whether that's a problem or not, we're really not sure. But if you don't have to erode the dentin and possibly weaken the dentin, why not just let's use a solution which will remove the debris but not destroy some of the collagen matrix of the dentin. And then we have classic protocol number 3, where people would use the EDTA to remove the smear layer, and they thought, well, let's go ahead and put chlorhexidine in so it can get into the tubules and kill bacteria, and also use that substantive effect of chlorhexidine. But there may be a problem with this, and I'll show you that in a couple of minutes. Here's the better protocol, which I now use. I use sodium hypochlorite, and I follow that up by Q-Mix 2-in-1 solution. What is in Q-Mix? It has EDTA, which we use to help remove our smear layer. It also has chlorhexidine, which causes us to allow that material to get into those tubules, and a surfactant, which causes it to flow into the smaller areas which we may not be able to get into without the surfactant. So why Q-Mix 2-in-1? It has a dual action. It removes the smear layer, but it also has an antimicrobial activity, and that it kills 99%. Hear that number again, 99% of planktonic bacteria in only 5 seconds. It comes in a pre-mixed container, so it's already ready to use and has a 2-year shelf life. And it's effective in penetrating biofilm and killing biofilm bacteria. That's a huge, huge benefit. And it's very fast, 60 to 90 seconds. So let me show you this picture of what happens with different vials, EDTA, chlorhexidine, Q-Mix, and chlorhexidine and EDTA if you add 1 drop of sodium hypochlorite. The reason this is important is because you have any sodium hypochlorite still sitting in a canal and follow it up with one of these materials, we want to know what happens. And after 1 second, you'll notice the chlorhexidine and sodium hypochlorite forms this red precipitate. The Q-Mix, which contains chlorhexidine and EDTA, does not really form a precipitate. It gets cloudy for just a little bit, but then you'll find that that goes away. After 24 hours, you'll see there's no precipitate in the Q-Mix, but if you look at the chlorhexidine vial, you will see there is a red precipitate in there. That's parachloroalanine, which is a carcinogen, and we'd never want to have that in our canal spaces. This is what happens to biofilm, this polysaccharide layer where bacteria is hiding in the midst of it and covered over. And you'll see that after using Q-Mix, this is a 3D picture. The red area is where there's killed bacteria. The green area is where there's viable bacteria. And there's only one little spot that you can see in this 3D image where there is a little bit of viable bacteria. Q-Mix penetrates biofilm well and kills the bacteria within biofilm. This is what our dentin looks like after sodium hypochlorite and Q-Mix. And you'll notice that after our 60-second to 90-second application of Q-Mix in the canal, you see dentin, but you don't see erosion. You see open tubules, and you don't see erosion. This allows that chlorhexidine to get in and give us that substantive effect that we want. So, this is my final irrigation protocol. I instrument the canal with sodium hypochlorite. until I'm ready to obturate that canal. In the section on obturation, you'll learn about using a size verifier, but I use a size verifier while there's still sodium hypochlorite in the canal. Because if you need to use the size verifier to do a small amount of instrumentation, you're going to have dentin chips in that canal. So I never put my size verifier in a dry canal. I then irrigate with sodium hypochlorite to get all that debris out of the canal space, and I fill my chamber with sodium hypochlorite. Now I go in with my endo activator for 30 seconds in each canal. I then irrigate one more time with sodium hypochlorite. Remember our rinse cycle of a washing machine? This is rinsing all that debris out. I then dry each canal to remove the excess sodium hypochlorite. I then use Q-Mix, 2 milliliters in the tooth, and you're going to let it sit for 60 to 90 seconds. While it's sitting in that canal or in the tooth, I use an endo activator for 10 seconds in each canal to activate my Q-Mix. And then after the 60-90 seconds, I dry the canals, and now I'm ready to obturate. So we spent a lot of time talking about our irrigation techniques and how we get to the point where we're ready to obturate the canal. But we need to spend a little time talking about 1 versus 2 visits. In my own practice, it occurred to me that I needed to think more about my irrigation protocol, and if I don't have enough time to do my irrigation protocol properly, then I do it in 2 visits. The whole 1 versus 2 visit endodontic discussion came about because everyone used to do it in 2 visits. But studies determined that it's not more successful to do it in 2 visits versus 1 visit, so that's why people have gone to 1 visit endodontics. If I do it in 2 visits, then a lot of times I will use only calcium hydroxide. And the question is, who cares whether you do it in 1 visit or 2 if you're having the same success rate? And why do it in 2 visits and have to have the patient come back if you don't have to? So here's the case that I did with the irrigation protocol that I use. And this is the type of thing that you can expect to do. This was a tooth that had a necrotic pulp in it, but had a very small radiolucency at the root end. The furcation area had a very large radiolucency, so my thought process was that there were probably a couple of large lateral canals. Even with that thought process, I did not do anything any different than my normal irrigation protocol. And when I obturated this, I was ecstatic to see the result that I got. A couple of things to notice. First of all, you can see in the furcation area where my irrigation protocol opened up lateral canals and my obturation material flowed into those lateral canals. And if you look at the apices of these teeth, you'll see several portals of exit that were obturated because my irrigation solution got down to this area and cleaned that area. But it was not just the needle that got down there, it was the endo activator that allowed that solution and the hydrodynamic action of my irrigating solution to get down to that area and clean those portals of exit. Thus, we see them obturated and a wonderful result. So I did that last tooth in 1 appointment. And so at what time do I do it in 2 appointments? I have changed a little bit over time in that I do a lot more 2 appointments based on the fact that I've got to have proper irrigation. The reason we went from 1 to 2 visits or 2 visits to 1 was based on success studies. We used to think that you needed to do all 2 visits if it was a necrotic tooth. But success rates have shown that it's no more successful doing it in 2 than 1. There's a controversy with that if you use a medicament of calcium hydroxide. You can find studies which say you get cleaner canals both ways, with or without calcium hydroxide. But the success rate has not been shown to be very much more. So, why do we care about whether we do it in 1 or 2 appointments? Are you having more success by doing it in 2 appointments or 1? And so why do more? Why do 2 appointments if you can do it in 1 appointment? If you have your canal clean, you have it dried, and you can go ahead and obturate it at that same time. Why not go ahead and do that if your success rate's going to be about the same? That being said, irrigation of a high quality is incredibly important with a necrotic tooth. Otherwise, lots of bacteria and necrotic tissue are going to be left in the canal, and thus you can expect a poorer prognosis. So, if I do not have time to do my proper irrigation, I put calcium hydroxide in and bring the patient back and obturate it another time when I can get through my correct irrigation protocol. So when do I do 2 visits? I do it if there's not enough time and I don't want to rush. I do it in canals that cannot be dried with exudate or blood coming out of the canal, and I need to use the calcium hydroxide to kill some bacteria and also to change the pH at the root end of the tooth with that calcium hydroxide that leaks out the end. In certain resorption cases, I'll do in 2 appointments. But if it's a large lesion or the patient's symptomatic and you can get that tooth dried, why not go ahead and obturate it? Because if you have to treat it, you're going to have to use antibiotics or something else like that. How many times have you opened up a tooth that was symptomatic that you thought, oh, I'm just going to open it back up and, quote, let the air out, and nothing was there but a dry canal? You're going to treat that tooth with antibiotics anyway, so why not go ahead and obturate those teeth at that time period? This video will show you that calcium hydroxide is put in using a lentulose spiral because you want it to be down in the apical part of the canal space. But make sure your lentulose spiral does not bind or it'll break. So, we have talked about irrigation and how important I think it is. And we have to maximize the quality of every step in endodontic treatment. And I also want to re-emphasize, do a root canal on your patient like you would do it on yourself. Or if you were sitting in my chair, how you would want me to do it in your mouth. And I hope that we have shown you that with the proper irrigation techniques and the protocols that it's easy to do, and you as a general dentist can do this just like I can as an endodontist.